Did you know 58% of women don't even know what a normal cycle looks like? And only 13 to 16% experience that classic 28-day cycle with fertile ovulation on day 14. That means most of us have no idea what our own fertility patterns actually look like. And that disconnect can cause confusion, missed chances, or hidden health issues. In this video, we're going to break down what your cycle really does each month and how to decode it for your fertility and long-term health, so you're able to figure out your own body. It is a balanced video with a technical explanation where I bring the real life explanation of how it works or things to watch out during your cycle. So stay tuned and watch the video. Hi, I'm Eva. I'm a wellness educator, IVF warrior, and one of the voices behind Wholesome Fertility. I am the female voice, and we have my husband for the gentleman. This channel is here to help you decode your fertility journey step by step with real science and relatable guidance. Whether you're just getting started, navigating IVF, or healing after loss, this space is for you. New videos drop every week, so if you want trusted insights, heartfelt support, and practical tools, make sure you hit subscribe. This video is part of our Foundations of Fertility series, where we break down the basics like menstrual health, ovulation, and how conception really works. So if you've ever felt confused or overwhelmed, this series is made for you.
The menstrual cycle refers to the regular changes in the activity of the ovaries and the endometrium that make reproduction possible. The endometrium is a superficial layer of the uterus, and it consists of a thin base layer and a functional layer, which is subject to these changes. So, the menstrual cycle actually refers to two interconnected and synchronized entities: the ovarian cycle, centered around the development of the ovarian follicles and ovulation, and the uterine cycle, centered around the way in which the functional endometrium thickens and sheds in response to ovarian activity.
The ovarian cycle is the important part for the fertilization of the egg by the sperm during conception. And the uterine cycle is important for your overall health, hormone balance, and it is especially important for implantation and a successful pregnancy.
At a certain point during puberty, menarche will occur, which is when a girl has her first menstrual period. From this day, the menstrual cycle starts and will continue to cycle until menopause, which is when the menstrual cycle stops.
The age at which the first period starts has been connected to chronic illnesses as endometriosis. Hence, the earlier start of menarche can be a sign to a possible undiagnosed illness that may impact fertility in women. Menopause is technically just a year, and it can only be seen in hindsight, as it is when a woman has not had a period for 12 months. Hence, anything before these 12 months is perimenopause. Unfortunately, most doctors do not recognize perimenopause, but according to different practitioners, it can start up to 10 years before menopause. So perimenopause impact on hormones, ovaries, quality of life, etc. may also impact fertility unknowingly.
The menstrual cycle can vary from 20 to 35 days, but we'll refer to an average 28-day menstrual cycle.
The 28-day cycle is only an average, so the fertile window and other number of days mentioned in this video apply to this average and is not a hard rule for everyone's menstrual and ovarian cycles. That said, if your cycles are longer than 35 days, it is important to consult your doctor, as this may be connected to different things like PCOS, menopause, perimenopause, etc. If your menstrual cycle is shorter than 20 days, it is also important to get checked, as this may be due to hormonal imbalances or other illnesses.
A new menstrual cycle begins on the first day of menstruation, and ovulation occurs 14 days before the beginning of a new cycle. So for an average 28-day menstrual cycle, this means that the pre-ovulatory and post-ovulatory phase both last 14 days.
It is crucial to mention that even in a 28-day cycle, the follicular or pre-ovulatory and luteal or post-ovulatory phase may be longer or shorter than the 28 days average. For example, when I and my husband were trying to conceive naturally, we would have missed my ovulation and fertile window if we only followed this average 14-day rule. At the time, I made use of different methods to measure and track my ovulation. I'm talking about ovulation strips, I'm talking about measuring my body temperature, the calendar, and all these things, as well as my cervix and everything. And despite my cycle being 28 days, I was ovulating on average on day 7 to 9. And my period usually would last 5 to 7 days. So this meant that if I waited for day 14, my ovulation would have long gone. But at the same time, we were limited to 2 to 3 days window to do anything to try to conceive naturally. As before that, I would be bleeding. By ovulating on day 7 to 9, my luteal phase was also much longer than 14 days. I do want to add that I have endometriosis, fibroids, and back then I had ovarian cysts and polyps that were later removed through surgery. So obviously I have a stacking of different things that add up. That said, a healthy luteal phase is usually 10 to 16 days. Shorter than that may reduce your chances of implantation. And also stress can delay ovulation. Even if your cycle length seems normal, so the 28 days, you might ovulate later than usual or even earlier than usual, which shortens if you ovulate later, it shortens your luteal phase without you realizing. And sometimes the corpus luteum, so the shell left after the egg is expelled, doesn't break down properly and becomes a cyst and continues to produce progesterone. These can delay menstruation and make the luteal phase seem longer. Symptoms might include pelvic pain or bloating. And this was my case, as my ovulation was early, but my luteal phase was long, but I still had a 28 days cycle. Again, these are all reasons to track your own cycle and to know your body. And if there are imbalances, check it with your doctor and rule out any illness or anything like that.
The 2 weeks before ovulation is the ovarian follicular phase, which corresponds to the uterine menstrual and proliferative phase. The 2 weeks following ovulation is the ovarian luteal phase, which corresponds with the uterine secretory phase. Let's start with the ovarian follicular phase, which starts on the first day of menstruation and represents weeks 1 and 2 of a 4-week cycle. The whole menstrual cycle is controlled by the hypothalamus and the pituitary gland, which are kind of like the masterminds of reproduction. The hypothalamus is a part of the brain that secretes gonadotropin-releasing hormone, or GnRH, which causes the nearby anterior pituitary gland to release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. Before puberty, GnRH is released in a steady amount, but once puberty hits, GnRH is released in pulses, sometimes more and sometimes less. The frequency and size of GnRH pulses determines how much FSH and LH will be produced by the pituitary.
These two hormones are responsible for ovulation signaling, the ovaries to produce follicles and to expel the egg.
Pituitary hormones control the maturation of the ovarian follicles, each of which is initially made up of an immature sex cell, or primary oocyte, surrounded by layers of theca and granulosa cells. On the surface of the ovaries, a couple of ovarian follicles compete with one another to grow the fastest during each menstrual cycle,
which will be about dominant follicle selection comparison. This is basically survival of the fittest. The best follicle is the one chosen. It is also important to add that every month the body chooses different follicles and the best is chosen while the others are discarded.
During the first 10 days, theca cells develop LH receptors, which allows them to bind LH, and in response they secrete a large amount of androstenedione. Granulosa cells develop FSH receptors, which allow them to bind FSH and produce an enzyme called aromatase. Aromatase converts androstenedione from the theca cells into 17-beta-estradiol, which is a member of the estrogen family. As follicles grow, the level of estrogen in the blood increases, and it acts as a negative feedback signal. That is, it tells the pituitary to secrete less FSH. Less FSH in the blood means there's only enough to stimulate one follicle. The follicle that has the most FSH receptors grows the quickest and becomes the dominant follicle, while the rest of the follicles regress and die off.
When doing IVF, for instance, not all follicles mature well enough or have eggs inside. So while it may sound like a waste that some follicles are discarded, most likely they were not ideal. And the body produces more than needed to choose the best one with better chances of success and survival.
Meanwhile, during the first few days of the cycle, the uterus goes through the menstrual phase, which is when the endometrial lining, also called the functional layer from a previous cycle, along with some blood, is shed and eliminated through the vagina. During days 10 to 14, in addition to the FSH receptors, the granulosa cells also begin to develop LH receptors. Meanwhile, the dominant follicle keeps secreting estrogen, and the rising estrogen levels make the pituitary more responsive to the pulsatile action of GnRH from the hypothalamus. As blood estrogen levels start to steadily climb higher and higher, the estrogen from the dominant follicle becomes a positive feedback signal. That is, it makes the pituitary secrete a whole lot of FSH and LH in response to GnRH. This happens a day or two before ovulation, and the massive surge of FSH and LH binds to the granulosa and theca cells, which help facilitate rupture of the ovarian follicle and release of the oocyte. You can think of it this way: for the most of the follicular phase, the pituitary saves its energy, and when it senses that a dominant follicle has really proven itself, the pituitary uses all of its energy to secrete enough FSH and LH for ovulation.
At times, the body may have hormonal imbalances that may impact this process and fertility as a result. For example, PCOS may impact the amount of luteinizing hormone, or LH, and can cause persistently high levels of LH, leading to false positives on ovulation tests. Also, with PCOS, the woman may have more follicles produced than normal. On the other hand, menopause shows high FSH, which can have an impact in the process. Also, menopause lowers estrogen, hence impacting things like libido and cervical mucus, which can make it harder for the sperm. Other things like endometriosis can impact the estrogen, progesterone ratio, and so on. These are hidden issues to fertility.
The spike in estrogen is aimed at optimizing the chance of fertilization, which is highest between day 11 and day 15 of an average 28-day cycle. During that time, the high estrogen levels change the consistency of the vaginal mucus, making it more hospitable to incoming sperm.
Besides tests to check your hormones and ovulation test strips, other ways to see if you are ovulating is by connecting with your body and noticing different signs, as increased libido. This literally means being more in the mood for sex around specific times of the month that usually assigned for ovulation and your fertile window. Egg white type cervical mucus coming from the vagina. So like that stickiness of egg white, the same consistency. Also changing the cervix depth, which can be measured by inserting a finger in the vagina and seeing if it has moved. It moves throughout your cycle, throughout the woman's cycle. Some women can also feel when they ovulate, which can be a pain on the lower pelvis, or you can even notice spotting, which is brownish or very light bleeding.
Additionally, the uterus goes through the proliferative phase, which is when the functional layer of the uterus thickens and the uterine glands grow. During this phase, spiral arteries emerge from the basal layer to serve the growing endometrial layer. Right after ovulation, while the LH levels are still high, the remains of the follicle turn into the corpus luteum, which is made up of luteinized theca and granulosa cells. Luteinized theca cells respond to the low concentrations of LH after ovulation by producing progesterone, but luteinized granulosa cells also secrete inhibin, which inhibits the pituitary gland from making FSH, so estrogen levels then fall. Overall, this means that progesterone surpasses estrogen as the dominant hormone, and it makes the endometrium receptive to the implantation of a fertilized gamete. Progesterone acts as a negative feedback signal on the pituitary, so FSH and LH levels fall. Progesterone is like an alarm, letting the body know that ovulation has occurred and that it's time to halt LH and FSH production until the next menstrual cycle. Under the influence of progesterone, the uterus starts to go through the secretory phase. That's when the spiral arteries grow even longer and the uterine glands secrete more mucus. After day 15, though, the window for fertilization starts to close. The cervical mucus starts to thicken and becomes less hospitable for the sperm.
Phase and progesterone could add how this phase is key for implantation. Some spotting during the luteal phase can be normal, like implantation spotting, but spotting early in the luteal phase might be a sign of low progesterone, which may increase risks of miscarriage.
Over time, the corpus luteum is gradually replaced by a white scar called the corpus albicans. The corpus albicans doesn't make hormones, so estrogen and progesterone levels slowly decrease. When progesterone reaches its lowest level, the spiral arteries collapse and the functional endometrial layer gets ready to slough off. This leads to menstruation and the beginning of a new menstrual cycle and another attempt at fertilization.
Around the same time, you can see changes in the body that shows that the fertile window is gone. So change in libido, cervical mucus, cervix location, how deep it is. And if you do usually get PMS, you will start noticing PMS symptoms. In my case, I start getting bloated straight away, and the other PMS symptoms will slowly show up as well. Some women have PMS, which is premenstrual syndrome, and this may show up as tender breasts, spotting, bloatness, insomnia, craving carbs, chocolate, or fats, constipation, or diarrhea on the days leading up to the period, irritability and mood swings, feeling tired, and so on. So it depends on the person. There are different symptoms you can have. Also, some women have PMDD, which is a severe PMS, and have worse symptoms and can even make her depressive. It is also important to add that PMDD is more common on women in perimenopause.
Alright, so as a quick recap, the menstrual cycle begins on the first day of menstruation. For an average 28-day menstrual cycle, the changes which occur in the ovary during the first 14 days are called the follicular phase. Ovulation occurs at day 14 as a result of the estrogen-induced LH surge. The last 14 days are the luteal phase. The follicular phase begins with menstruation, and while the length of the follicular phase can vary, the luteal phase always precedes the onset of menses by 14 days. For the uterus, during the first 14 days, it goes through the menstrual phase and the proliferative phase, and during the last 14 days, it goes through the secretory phase.
So now, if you are a man, these are some questions that can help you. Can you notice changes in your partner? Can you notice if she still has libido or if it has changed? And how is her mucus, her cervical mucus, so the lube? Is she still able to produce enough, or do you need lube before intercourse? Are you able to identify when she's in her fertile window? Does she have PMS or premenstrual syndrome symptoms like pain, spotting, tender breasts, irritability, mood swings, insomnia, and so on? If you are a man, this is an important question for you. Do you know your sperm health? Because timing won't matter that much if motility or morphology are off. That's what we'll explore in our upcoming male fertility video. If you're a woman, the following questions are important and will help you. The first question is, what's the length of your cycles? Does it fall within what is considered normal, 20 to 35 days? If not, are they regular or irregular? What symptoms you notice in your body? How are your periods? Do you notice the fertile window signs? How is your luteal phase? Do you have PMS? Are the symptoms and your cycle still the same, or have they changed? Next in the series, we'll be diving into male infertility, what causes it, how it's diagnosed, and what treatments are out there. So if you're trying to conceive as a couple, you won't want to miss that. I hope this video helped you understand your cycle more clearly, because knowledge is power when it comes to your body and your fertility. Remember, this is part of our Foundation of Fertility series. If this resonated, don't forget to like, subscribe, and turn on notifications. If you're navigating questions or challenges around fertility, know that you're not alone. You deserve support, you deserve answers, you deserve to be heard. So if you have some questions, drop them in the comment box below and we will address them in the upcoming videos. Till next time, be kind to yourself and take care of your body, mind, and heart. Thank you.